Thank you very much. I appreciate that. This is going to be sort of a two-part discussion today. I'm going to start today just working through some of the basics of child physical abuse, as well as some new trends in child abuse, such that we are going to include some pearls as well as some new directions, and I hope that we have a little bit of everything in that segment of our presentation. And then secondly, we're going to work through a case presentation from our institution where we're going to involve our panel members who are available to discuss and answer questions as they arise. And I greatly appreciate their presence here, and I'm going to introduce them. So one is Dr. James O'Neill, and he is an assistant professor in the Department of Emergency Medicine and an integral part in our team as a team member in the emergency department. And we'll talk a little bit more about our interface with the emergency department. Elizabeth Goodman, who has more letters after her name than I've ever seen, and I can say she absolutely deserves it. She has many different jobs. Importantly, she is the sexual assault nurse coordinator and the forensic nurse coordinator, and that has been, again, critical in our team development. And then lastly, Detective Jennifer Dobie from the Winston-Salem Police Department. And again, we work together probably more than we would like, but we work together a lot, and we appreciate her coming today. So again, we're going to work through a case second, and we'll be able to involve our panel members with questions and points as we go through that. But let's start again just with some general statistics. So we know that child abuse happens a lot. How often does it occur? So over 1 million cases in 2006, but these are just the substantiated cases of child abuse and neglect. 2,400 of those were deaths, and we know that the most at-risk group are the youngest regarding serious injury and death. This is just the tip of the iceberg. Some have estimated between 1% and 15% of all ED visits are related to non-accidental trauma. 4 types of abuse. We're going to talk about physical abuse today, neglect certainly being the most common, followed by physical abuse and then sexual abuse. Emotional abuse, I would think that happens all the time, but you know, we just have pretty poor definitions for emotional abuse at this time, such that it's hard to statistically capture that. This is my only slide on sex abuse, and I just have to include it because it is so, I think, pertinent. 1 in 4 girls, 1 in 6 boys report that they've been the victims of some sort of sexual maltreatment by the time they hit 18 years of age. Some feel that this statistic from a male perspective is lower than females because they're more likely to underreport, so incredibly common. What about resources? So some have estimated $7.7 billion directly as a result of child abuse and neglect yearly in our country. 2 times longer hospitalizations, 2 times the number of diagnoses, and 2 times the number of costs. And this is interesting. They've compared groups of severely abused children, especially abusive head trauma, to those that were accidentally injured, and the outcomes in the abusive head trauma groups are, time and time again, more severe, even though the injuries can be similar. This is the indirect costs in addition to the direct costs, and every time I gave this presentation initially, I would look this up again because I would think, did I get that wrong? And I didn't. So $95 billion, and that's taking into account these other indirect expenses, loss of future earnings, quality of life, etc. So we're spending the money on child abuse and neglect, and that certainly has been important. These statistics have been important when trying to figure out how we can spend those resources more efficiently in the area of prevention, for instance. This is just interesting. These have been recent trends in child abuse statistics. There are 2 real data banks that we use, NCANS and NIS. NCANS is from DSS, so they essentially tell us how many cases have been substantiated. You can see why that might be an underrepresentation of all child abuse. And NIS involves a few other groups of mandated reporters like the police. And so they're all showing declines in child abuse. And I don't know how many of you all have that same experience in your workplaces, but that certainly isn't ours. So NCANS says that substantiated cases have dropped 55%. In NIS, that the substantiated cases of child abuse are down 23%. So again, these are things that make you go, because that's not our experience. So what is our experience? These are statistics up through 2011. We don't have 2012, and 2013 is almost gone, so that's not a good sign. But nonetheless, we are accruing those. So 2011, we have gone up every year. This was our 2011 tally. We had 913 child abuse and neglect cases where there was at least a suspicion of child abuse or neglect. We see a lot of kids in sexual abuse outpatient clinic, and that represents a large percentage of those numbers. Physical abuse, neglect, Munchausen syndrome by proxy, otherwise known as medical child abuse now, and emotional abuse. So we are seeing increasing numbers, which is in contrast to what folks are reporting with NIS and NCANs. Dr. John Leventhal saw this discrepancy and thought, well, that's interesting. What's our experience in the hospital? And he looked at a different group. He looked at kids that were discharged from the hospital between 1997 and 2009. And he indeed saw what we see, that there hasn't been a decrease, but in fact, there's been a statistically significant increase in the number of kids who are being discharged from our hospitals. This is interesting, a major demographic change in that the percentage of Medicaid patients has gone up, which underscores, and we'll talk about this in a minute, the contribution of poverty as a risk factor to child abuse and neglect. I had a mentor once tell me, if we're gonna solve the problem of child abuse, we're first gonna have to solve the problem of poverty. And I think that that's a wise statement because we so often see these two linked so closely. Again, incidence of dying in the hospital from physical abuse has gone up, and this is in contrast to hospitalizations as a result of non-intentional trauma, which have trended down. Recessions, so those of us who work in hospitals and were around during the economic decline in 2007 through 2009, we may have anecdotally thought that the increased risk, or that we were seeing more cases of child abuse, but studies have now documented that. One showed a doubling of cases of abusive head trauma, and I remember being on with Dr. Seinel, my prior mentor, and we saw 3 times the number of normal abusive head trauma cases in that PICU over the course of 2 months during one of the more stressful times economically. And so there certainly is a tie between poverty, economic stress, and non-accidental trauma. We've thought about why is there a discrepancy, and some may say we're just preventing child abuse more. That's what perhaps the NIS or NCANs might want us, not want us to believe, but we may be, I think, tempted to believe that. But again, our own experiences is different, and we worry sometimes that perhaps we're not, there are trends rather in how we're substantiating those cases of non-accidental trauma. All right, so some of the basics. We know with abusive head trauma especially that a third, and I remember the rule of thirds with abusive head trauma, a third are misdiagnosed initially, a third are mild to moderate, and then a third moderate, and a third severe. But a third are misdiagnosed initially. And who are we more likely to misdiagnose? This is interesting, and I think it's pertinent. And we talked a little bit about this, about emergency department presentations. Those who are younger, and that makes sense because they can't tell us they've been abused. Those who are white, because whether or not we like it or want to admit it, we have preconceived notions about what abuse patients look like. And although there is no relationship to race, meaning there is an increased risk with different races or minorities, we as physicians are more likely to report minorities than non-minorities. Those who have less severe symptoms, again, fairly intuitive. If you come in during the winter and you have a loss of appetite and increased irritability, that might match about 30% of the patients in the ED at any given time, are those who live with both parents, because again, we have this preconceived notion about what families who abuse their children look like. That's who we're more likely to miss. This is scary. So if we do miss it, and the child is discharged, up to a third will have repeat trauma, and that trauma can be incredibly severe. 75%, once we catch it, if we look back in the charts, we realize 75% had been injured before and had signs of trauma, which can be sad. This is our impact of poverty. 3 times the number of fatalities, 7 times the number of serious inflicted injuries, and 5 times the number of moderate inflicted injuries. And I think this is important, not to try and define cases, meaning not to determine who did or did not abuse their children, because we know that folks of all socioeconomic levels can abuse their children. But I think it is most helpful for trying to determine where we can invest resources for prevention. What about risk factors for child physical abuse? And again, a lot of these are intuitive, but I think they're important. Substance abuse and domestic violence are huge. And we talk about that with social histories, and it's incredibly important. Presence of more than 2 sibs in the home. When I first started doing this work, that was counterintuitive to me. I thought if there are more folks around, perhaps there'd be more eyes on all the time, but actually increasing numbers in the home increases stress. Twins, we certainly see are at an increased risk, and anytime we diagnose one twin with physical abuse, we are absolutely going to evaluate the other sibling in full with a skeletal survey. Low infant birth weight, unmarried mother, children with disabilities, 2 times higher, and that can be difficult. For instance, with our NICU graduates who may have poor bone mineralization because of medical complications, but we also know that they also are at an increased risk for abuse, and some of those cases can be really challenging. This risk factor I just wanted to put up here because I think it deserves a slide in and of itself. And I think if you've seen this once, you've seen it a lot. The mother who went to work and left the child at home, for instance, with the boyfriend who's not the biological father of the child. And so, again, we see that history present itself over and over, and they've actually done studies, one of which said that you're 50 times more likely to die of inflicted trauma if there's a non-biological caretaker taking care of you. And so, again, I think that's important. Not necessarily on a case-by-case basis to figure out who did it, but to think about prevention and education with the families when we're talking about appropriate child care. Okay, I like this slide because it comes up time and time again. What about the explanations that are frequently given for child abuse cases? Okay, so no explanation. This always amazes me. You would think in the day and age of Google that you could figure something out, but the most common explanation that is given is no explanation at all, meaning they don't have any reason why this child has horrible intracranial bleeding. The child just became unresponsive. So no explanation at all. And I've heard folks say, well, isn't it, and I've had this question on the stand more actually than in the medical arena, isn't it reassuring that the parents didn't tell you this or that happened? They didn't lie. But the absence of an explanation is in and of itself concerning, and it's very common. A vague explanation, an explanation that changes. Again, extremely important. And we were talking about this earlier, and I think an important point from an ED perspective, emergency medicine perspective, as well as when the child gets to the floor, that when folks take the history, they do so with very including the specifics and with great documentation. Because even in quotation marks, for instance, that can help us tremendously the next day when that story changes. And that may seem like a small thing, but that's actually a very big thing. And later on down the road can be one of the only red flags for concerns. Inconsistency with pattern, age, or severity of the injury. So certainly a child who rolled off the couch and now has devastating intracranial injury, there may be some concerns about that. What about the inconsistency with the developmental capabilities? The 1-month-old who rolled from the center of the bed off the bed, those can be concerns. Or different explanations from different caretakers. We get that too, and we may get that accidentally. And I will sometimes get that accidentally. So a mom will give the history in the emergency department, that's documented, I read it, and the next day when I go into the room, it's only dad who's there, and I get the history from him, which is very different. So it can be challenging regarding whether we choose to separate parents, because that often goes into that realm of investigation, and I like to think of ourselves as the medical team, so we don't always separate parents, although sometimes we do. But even when we don't separate parents, we can oftentimes see differences in their histories. Radiographic workup. What about the skeletal survey? We know that in kids under 2 years of age, it's absolutely recommended anytime there's a suspicion for non-accidental trauma. Between 2 and 5, we should use our clinical judgment. It can sometimes be helpful. And greater than 5, it's rarely helpful. But it is in certain circumstances necessary, such as when a child is unconscious and you can't get a good physical exam. For instance, we had a child who was 17 in the pediatric intensive care unit who was the victim of severe non-accidental trauma, and she certainly had fractures identified on skeletal survey. And then also important, and something we're doing more of now than we did 10 years ago, are repeat skeletal surveys in 2 weeks. This is a big take-home point, and I would like this to be one of your main take-home points. That follow-up skeletal survey is critical, especially with rib fractures, because when fractures are approximated, it may be difficult for us to see those. But as they heal, that callus formation becomes more obvious, and in 2 weeks, those can be very obvious, whereas 2 weeks prior, they were not seen at all. Let's see, so that's our, okay. So this is Kleinman. He actually did a study, and there were 2 studies talking about that, the helpfulness of that follow-up skeletal survey, and anywhere between 20 and 60% of cases there were additional fractures uncovered. And I think this is an important point, that even though this may not be incredibly pertinent clinically, it can be extremely helpful from a investigative perspective. For instance, all of these children that I see with multiple fractures, I will list and number those fractures, because 6 fractures versus 12 fractures makes a big difference to a judge, to a jury, to an investigator, to a DSS worker, et cetera. And I think we owe it to these kids to actually understand the full extent of their injuries so that we can articulate the degree of injury. All right, so this was a 2-year-old. She was over 2 years old. She was almost 3, and she was brought in because her stepmom said that she came in and she found the child playing with her razors, and then tried to wash the child's arm off in the sink. You can see this is a circumferential full-thickness burn, required a fasciotomy. And so I asked for photographs of the sink and a water temperature, and we do both of those, and there are certainly nuances regarding water temperature and time of exposure. But particularly interesting is the sink. There's no stopper in the sink. That's a soap, a bar of soap. So she said she ran the hand under this sink spigot, which just doesn't fit. It doesn't take a rocket scientist to figure that out. It doesn't fit with the mechanism of injury. She said this bruise was from the 3-year-old sister, and that this bruise on the head was because she ran down the hall and fell. And so in this situation, this was a child where we did get head imaging, and that was negative. She was over 2 years old. She was almost 3, but we still elected to get the skeletal survey because of this really big distracting injury, and because of the degree of trauma that we saw on the outside. And in fact, she did have a radius and ulna fracture. And you'll notice here the degree of callus formation, which is significant because this is at least 2 to 3 weeks old. And so that now gives us multiple injuries of different dates, right? So we have injuries from different times, and that can be significant regarding articulating the degree of trauma. And in this case, I think it was important for us to highlight this case. I think helps us highlight how that skeletal survey may be helpful in kiddos who are a little bit older. Sometimes the stepmom eventually pled to felonious child abuse. She said that she lost her temper with the child and burned her arm. And the father later admitted that since the stepmom had been taking care of this child, that the daughter had regressed with potty training and always acted incredibly fearful of the stepmother. What about head imaging? So this is part of this sort of new directions piece that I think is interesting. So what's the purpose of our head imaging? So we certainly want to detect injury. We want to get the full extent of the injury and determine who needs emergent medical intervention. But we also, another component of head imaging is to characterize the lesions that we find to try and differentiate them from other pathologies on our differential diagnosis. Head CT, we know it's fast. We do know it exposes the child to radiation, can be performed on critically ill children in a matter of seconds, and it's really sensitive for any type of skull fracture, for intracranial hemorrhage, and then also cerebral edema and mass effect, and it helps determine who needs emergent intervention. But what about the MRI? We are getting more and more MRIs on our non-accidental trauma patients, or where there is suspicion of non-accidental trauma. And why is that? So it can really help us characterize those findings. It can help us with timing of injury, if possible, not always, because we are learning that our timing can be challenging. But it really helps us characterize those findings. And it can be it can be much more sensitive to the intraparenchymal injuries that we may not pick up on CT scan. It does require sedation, of course, and no radiation exposure. This was a study in 2005 that showed in those kiddos who they got an MRI in addition to the CT, additional diagnoses were made on half of the children. And I must admit that this is my clinical experience thus far, that we will oftentimes be able to better characterize those extraaxial hemorrhages. For instance, is it subdural or is it subarachnoid? Is it benign enlargement of the subarachnoid space in infancy? Is it a hygroma, etc.? There are nuances that are much more clear on MRI that are not seen on CT. And while that might not make a clinical difference, that can absolutely make a difference when we're trying to figure out why is that fluid there. Again, new trends, imaging of the spine, and I think this is interesting. This was actually I'm going to start with a case. So this was a 4-month-old African-American male who came in recently. He had just some irritability, decreased eating, increased sleep. The baby was covered in congenital melanocytic nevi. So he had all of these congenital nevi covering his body, and there had been discussion about the possibility of him developing neurocutaneous melanosis, and they had seen a geneticist and a neurologist at an outside institution, I think it was UNC, and so there was automatically concern about some sort of intracranial pathology. And so they got a MRI on this infant, which did show bilateral subdural hemorrhages. And this was both supra and infratentorial. I only have one image from the MRI here today, but there was also blood around the left cerebellum. There was, however, no evidence on MRI scan of that neurocutaneous melanosis that potentially could predispose this child to subdural hemorrhaging. So there was no identified cause that we could see that would otherwise explain this child's hemorrhaging. And I think certainly trauma was on the top of was one of our ideas on the differential diagnosis, and continued to raise on the differential diagnosis as the neurologist, geneticist got involved and said we really don't see any other evidence of neurocutaneous melanosis. But what we did also do is get imaging of the spine, and that was because of this concern for neurocutaneous melanosis. And you'll see that there's subdural fluid collection that they predicted was blood around the lumbar spine posteriorly. So we had to stop and think about that. And this is an interesting component of the non-accidental trauma workup that's becoming more and more common. This was a paper that was released in 2012, and our neuroradiologists at Baptist have talked about this with me, and I think it is very interesting, and I know there's a lot more work to be done, but they looked at, and I have the numbers here, let me, I think it's in our next. They looked at a number of children who were admitted for abusive head trauma, 252, as well as those from accidental trauma. All of the accidental trauma patients had spine imaging, and only a percentage of the non-accidental trauma victims had spine imaging, like 25%. 56% of those had thoracic or lumbar spine imaging, and 63% of those that were imaged actually had subdural bleeding or extraaxial blood around their lower spine, which is fascinating because we don't typically image these children's lower spines. They may get C-spine imaging with MRI, but we don't typically get thoracic or lumbar. So there has been recent discussion, I know I've talked with Dr. Kuchar as well, of neurosurgery and the need for potentially getting more spinal imaging if we are getting the brain. And I think that it's helpful at least to think about this, knowing we need more studies, but certainly they wanted us to be increasingly aware of the possibility of spine trauma and extraaxial fluid collections, as well as thinking about the fact if we find it there, it may be more associated with trauma than non-accidental trauma than accidental. And to date, we still don't have a great answer for why this child had subdural hemorrhages and subdural hemorrhaging around the spine and the brain, although trauma is certainly high on the differential. And this family had a very chaotic social situation such that the maternal grandmother is now the primary caretaker, and mom is certainly okay with that. This baby was being cared for by mom's boyfriend, not the biological father of the baby. Again, not what we use to identify the abuser, but certainly a concern and a red flag. We know, however, that imaging of the spine is going to take additional sedation if we're getting the head MRI. And then what does it going to change our clinical outcome? Probably not. Most of these we've found go away on their own and don't, even if there is some small cord compression, don't require any surgical intervention. All right, so this is about timing and intracranial hemorrhages. I think this is an interesting and a very important point. So this is a little 2-year-old who was admitted to our hospital. Radiology looked at this MRI and concerned for bleeding of different ages, so acute on chronic subdural hemorrhage. And we used to think that we were a lot better at dating these collections than we currently know that we are. And there are some reasons for that, and I think it's important. So whereas we used to use acute and chronic, we more often use now mixed density. And I think that's important because this actually, when neurosurgery went in, found that they could certainly not confirm that this was of various ages. We know there are a couple reasons for that. One, blood can layer. So you can have acute blood that layers and causes this mixed density appearance. We also know, however, that the arachnoid can have small tears in it such that the CSF can leak from the arachnoid area to the dural area, causing this mixed density appearance very quickly. Whereas we used to think this mixed density was different ages, we now know that that can happen very quickly. And that's important. Okay, that's important for law enforcement, for instance. Knowing that we had 2 different age subdurals means a very different thing than 1 age subdural. So we have to be very cautious when we're dating these subdural hemorrhages. This was a great article that they had a good guess at the timing, and they found one image became chronic in 17 hours. So we had a similar experience in the hospital. Dr. Zapatka, the neuroradiologist, called me and said, you know, this kid just had an MRI, you know, a day ago, and now it looks chronic. This is one of those cases, and I thought that certainly was similar. This was another great study where they had subdurals that required draining. So they were draining these subdurals, and then they injected in the arachnoid space in the CSF around the spine a tracer, and that tracer quickly moved out the subdural space. So it did cross that barrier between the arachnoid and the subdural space very quickly. So that was a pretty interesting and eloquent study to show that we can have leakage of CSF into these subdural fluid collections, and they can look chronic or mixed density, whereas in reality they are actually all acute. So be careful when you're looking at these images if you're going to make any reference to timing. Rebleeding and neomembranes, I won't get into that today, but it is an interesting discussion in a sense that these subdural fluid collections can form their own neomembranes within, and that can cause bleeding from lesser trauma or no trauma at all later on down the road. Again, just articulates the difficulty we have timing these injuries. Okay. Another couple minutes and we'll move on to our case. So legal challenges and controversies. This is interesting. This was a paper in JAMA in 2012, and I cited it because I think it articulates the many challenges that we have moving forward on these cases. These challenges can be introduced sometimes by other expert testimony, and we see those challenges frequently, which may or may not be based on in the evidence. We also see these challenges introduced later on down the road from attorneys, and this was just one statement that they made, and I like to use the example. So I will frequently get the question, this father or this boyfriend or this mother has confessed. So do we need to do this workup? Do we need to go through all this? And I will tell you that there is no such thing as an airtight child abuse case. Those confessions are often retracted. The histories can change, and I think we need to approach these cases very methodically and and be very cautious, because there is no such thing as something that is just open and shut. There was a case where a father admitted to throwing the infant against the wall, and the child suffered devastating neurologic effects. In that case, eventually, after it was all said and done, that father was found innocent by the jury, and that happened in Forsyth County. So it's just a good wake-up call for me to remember that nothing is airtight, and we have to be careful at every turn. And that case did involve other expert testimony and certainly challenges from a legal perspective. Why are we having all of these challenges and controversies? Well, certainly there is this experience where some caregivers have been wrongfully accused, and that happens in every area of the law, in any area of the law. So that certainly is a concern. Most of the time, folks who study this think that that is incredibly uncommon, but we don't know the numbers. This was in the lay press in the New York Times a few years ago. I think it was about 4 years ago. Does anybody remember this? It was a really interesting article that brought into question this diagnosis of abusive head trauma. One reason why we don't call it shaken baby syndrome anymore, we call it abusive head trauma. Shaken baby syndrome implies that we know the exact mechanism, whereas we've actually interviewed perpetrators, and between 20 and 60% of perpetrators will confess to actually slamming the baby against a surface as well. And so shaken baby syndrome doesn't exactly account for that mechanism. So we use the term abusive head trauma. But we are certainly getting questions and challenges, and some of them appropriately so, from every angle. So I do think that that speaks to the need for us to be, again, incredibly methodical in our evaluation, as well as articulate in our discussion regarding assessment and plan. Another challenge, so retinal hemorrhages. Who remembers when retinal hemorrhages were pathognomonic for child abuse? Right? So pathognomonic, that's one word that I never like to use with child abuse, because it seems like all those things we used to think were pathognomonic are now no longer pathognomonic. We used to think we could date bruises. We can't date bruises. Retinal hemorrhages have been incredibly, have had a sort of there's been a lot of interesting information on retinal hemorrhages such that we know a lot of things can cause mild, maybe even moderate retinal hemorrhages. Very few things cause severe multi-layered retinal hemorrhages, especially retinoschisis or perimacular folds, for instance. So not all retinal hemorrhages are the same, but when certain retinal hemorrhages are present, they are incredibly helpful to us, and we know that very few things cause severe and horrible retinal hemorrhages, such as birth trauma, abusive head trauma, and crush injuries. We had a case in our hospital where a child's head was crushed by a TV. And so there are a few things that can cause severe retinal hemorrhages, abusive head trauma among them. Responsibility to report. I just have to include this slide. I'm not going to include this discussion on the sex abuse scandal in Pennsylvania, although I think it's interesting. But in the essence of time, I'm just going to skip to the fact that we are all in North Carolina mandated reporters. What does that mean? That means if we have a suspicion that a child is being abused, we are mandated to report. That doesn't mean that we have to wait until we confirm that suspicion, and I think that is important. It can take months to confirm a suspicion, and it may be impossible to ever confirm a suspicion, but as soon as that suspicion arises, we're responsible for reporting to DSS, and if there's serious injury or any illegal activity, to law enforcement as well. In every state, there is a good faith reporting law, and that means if you report and you are wrong, you at least have a law there to help support you if you are sued regarding in your heart of hearts that you believe this child was abused, and then you will therefore be protected from any sort of civil litigation following that. A good example, there was a physician who sent nucleic acid amplification testing for gonorrhea and chlamydia, and one was positive, and there was subsequent action, and the child was removed from the family. It turns out that was a lab error, and the NAT was negative. Now, is that a horrible thing? Absolutely. Does that doctor then face civil suit because they made an erroneous report? No, they're protected because in their heart of hearts, they believe that child was being abused. Doesn't mean somebody can't sue you. My sister's an attorney. I said, they can't sue you over that. It's America. Anybody can sue anybody, which is true, but they can sue you, but you are protected if in your heart of hearts you think a child's being sexually abused or physically abused and you make that report. But you do want to be careful. I always call the lab if I ever get any abnormal lab on an abused child, and we look at it together. Okay. So now we're going to move into our case. And at the completion of our case, we're going to have a discussion, and we're going to be open for questions. And I hope that this case highlights a number of experiences that are common to our cases at Baptist Hospital, and then we'll go over it together. Okay. Whoops, I need to introduce the case first. Okay, so this little baby is a 3.5-month-old white female who presented to the emergency department because the infant had bilateral leg swelling, specifically swelling of the lower legs. Again, 3.5-month-old white female. Mom brought the baby into the emergency department and said the baby's been really fussy for the last few weeks, but particularly fussy for the last several hours this evening. She brought him in late in the evening. She said the legs have been big, firm, and swollen just this evening. I noticed it just tonight. I haven't noticed this at all in the past. Yesterday, the day before, a week ago, legs were completely normal. In fact, in the last 2 weeks, the mom had taken this child to the pediatrician 3 times in the last 2 weeks. So, well, about 2 weeks, maybe 2.5 weeks. 19 days prior, the dad called the pediatrician's office and said, my baby is screaming, has been crying for 3 hours, and I can't get this baby to be quiet. And they said, okay, we'll bring the baby in tomorrow, we'll look at him. And the baby went to the pediatrician's office, had a normal exam, and was diagnosed with gastroesophageal reflux and treated with Zantac. 15 days later, the mom called the pediatrician and said, this baby has not stopped crying for 4 days. Baby was once again examined and reassured the exam was normal. And then 10 days prior, the baby was taken back to the pediatrician because of continued fussiness. Baby had a temperature to 100.4, was given ceftriaxone, blood culture, urine culture were negative, otherwise normal exam, and continued reflux precautions. But that's just an example, an interesting example of this child's interface with the medical community in the days leading up to the diagnosis. How about some significant past medical history? So mom's 21 years old, dad's 17 years old. It was a normal pregnancy aside from the fact that she had an MVA, rear impact, low speed, in the 8th month, and was observed for a few hours, but there was no noted abnormality with mom in the observation unit. She's a vegetarian, but she did take prenatal vitamins. And this baby has been purely breastfed since birth, has never gotten formula, and has never gotten vitamin D or D-Visol. So what do we know about purely breastfed babies? That they're at risk for vitamin D deficiency or rickets. So this baby is now 3.5 months old. At about 2 to 3 months, our liver stores are depleted, and babies need to have that supplementation. This baby has had no supplementation and is purely breastfed. All important information. Has been diagnosed with GERD and has been fussy since about 6 weeks of age. What else starts around 3 weeks, peaks at 6 weeks, colic, right? So this baby had been diagnosed with colic as well, so extremely fussy. Social history, mom and dad both deny domestic violence, and for every consult I do, I say the following. I say, I don't want this to offend you, but it's important for me just to take a really detailed social history. Tell me about domestic violence, alcohol or drug abuse, any history of physical abuse, any concern that anyone's ever hurt your child. They both denied domestic violence. We later found out from law enforcement that police and DSS had been called multiple times for domestic violence. The father had a history of PTSD, and there was a 2-year-old sibling in the house. She had a different biological father, but she had no injuries or concerns. She had a completely negative past medical history and eventually had a negative workup. Okay, so let's see. So in the emergency department, they started with plain films. Here's our physical exam. Sclera are white. Why am I looking at the sclera? We think about, with fractures, certainly any other genetic or metabolic bone disease, sclera specifically for osteogenesis imperfecta. Some of those children have blue sclera, not all of them. This baby's sclera were white. The legs were swollen and between the knee and ankle. No bruises noted anywhere. If there were bruises, we would have requested the help of our forensic nurse examiners to take photographs. And even photographs of this child's swollen legs would have been certainly a great thing. But nonetheless, photos at the time of presentation can be helpful. And the baby was fussy with movement of the lower extremities. So here I haven't included the whole skeletal survey, but here are the legs. Bilateral, metaphyseal, distal femoral fractures. You can see the periosteal reaction here. That's secondary to bone injury. Bilateral tibial metaphyseal fractures. Metaphyseal fractures are one of the 5 most highly specific fractures for non-accidental trauma. So posterior rib fractures, metaphyseal fractures, spinous process fractures, sternal fractures, and scapular fractures are your 5 most highly specific fractures for child abuse. So here we've got our metaphyseal fractures. The tibias bilaterally are fractured through and through. You can see that. Maybe an oblique and oblique. It's hard to tell spiral from oblique on x-rays at times, perhaps even transverse. The fibulas are fractured but not through and through. Bilateral, distal, tibia, metaphyseal fractures here. The baby also had a humerus fracture, a definite humerus fracture on one side, a potential humerus fracture on the other, to total 12 fractures in full. No rib fractures, but 12 fractures in full, 2 other possible fractures. Let's see, let's go on. Here are all the fractures that we just talked about. Here are our laboratory findings, and this is where it gets interesting. So, at least interesting for me, perhaps not for everyone else. Elevated alkaline phosphatase to 872, so that's definitely elevated. A normal phosphorus and a normal calcium, and a vitamin D of 7. So vitamin D is tough because there are so many of us in the population, including children, who have vitamin D insufficiency or deficiency. Who here has been diagnosed with vitamin D? You don't have to raise your hand, but a lot of people, right? It's sort of a new thing for us to check, and we are seeing that a lot of folks are insufficient. And this baby was among them, and we knew that was going to happen because we're completely breastfed up through 3.5 months of age with no vitamin D supplementation. What do we see from a laboratory evaluation for vitamin D deficiency? We see low vitamin Ds, and then we look for high parathyroid hormone. And our parathyroid hormone was normal because your PTH goes up as you have vitamin D deficiency. So our PTH being normal is really helpful, and that can be a very sensitive marker, as well as elevated alk phos. So this alk phos is high, it's really high, but then we have 12 definite fractures that are in the process of being remodeled, which might also explain an elevated alk phos. ASTs were slightly high, but then repeated the next day were normal. We sent DNA testing for osteogenesis imperfecta, which, although expensive, I think is very important, especially in those infants who are primarily just have fractures. And so we did so in this case, as well as got a genetics evaluation, and that was negative. And this is sensitive for 90% of cases of osteogenesis imperfecta, not 100%. Follow-up vitamin D 6 weeks later was 40.6, and interestingly, the grandparents brought the baby back to clinic and said, this is the happiest, best baby. She doesn't cry, she acts beautifully, so I thought that was interesting. One concept that continues to arise is that infant who, if they had severe genetic or metabolic bone disease causing 14 fractures in the first 3 months of life, it is unlikely that all of those would go away with a change in environment. Does that make sense? So I think it's helpful when we see them in follow-up and see how well they're doing or not well. If they continue to have bruises and fractures in a protected environment, that is concerning and causes folks to go back to the drawing board. Okay, so radiographs, the bones were normally ossified, important because we want to look for all those things like rickets and osteogenesis imperfecta, etc. No evidence of rickets. Vitamin D deficiency, if it goes on long enough, causes rickets. If it's severe enough, it causes rickets. No evidence of OI, and all of the fractures, all of them, were felt to be 2 weeks old. So then that leaves the doctors and the investigators to say, what in the world? This baby's symptoms just started tonight. The legs just got red and swollen and firm tonight. Yet all these broken bones are 2 weeks old, so something's not right. Well, so law enforcement continued to investigate, and also the day before, this baby was taken used car shopping with family members in a onesie, and even the used car folks said, yeah, the baby looked completely fine to me. And they had pictures of the baby on the phone the day before. The legs looked completely normal. So this baby's legs acutely got red, big, and swollen, and the baby has 12 fractures, all of which are 2 weeks old. Things that make you go, right? Okay, so follow-up skeletal survey was negative. Dilated eye exam was negative, genetics consult, no other concerns, and we discussed with endocrinology. Just a little more social history before I move forward to our endocrine sort of discussion is, so upon further questioning of the mom, law enforcement found that 2 weeks prior to this child's presentation to the emergency department, mom and dad had gotten in a fight and dad had left the house. The night of presentation to the ED, the dad had come back, and he was in the home for the first time that evening. Mom gave the 2-year-old a bath while dad got the baby ready for bed. And it was after that time with dad that mom initially noticed the symptoms. So that's just a little more information that we received from law enforcement that could be helpful. All right, so here's some questions asked by investigators. How could all of these be 2 weeks old? The baby saw the PCP multiple times in the 2 weeks leading up to the evaluation, and nobody saw anything wrong with that baby's legs. Well, it's actually fairly common for babies to have broken bones and no one to be able to tell it from the outside. Babies have short, chubby legs, and the orthopedist said in this particular case, the fibulas were not fractured through and through, such that they probably splinted the lower leg, that there was no gross deformity. There was concern, and I think this is an appropriate concern, that at least when these initially happened, there were some findings 2 weeks prior, and there was some concern that mom initially knew that this child had injuries. But at least during that 2-week interim, even the physicians who saw this baby could not tell these fractures were there, and they were there. And it just reminds us that you can't always tell on the outside if there are fractures on the inside, just like we can't always tell on the outside with infants if there's intracranial abnormalities. And that's why we do screening skeletal surveys and head imaging in these very young infants. Okay, even better question from a legal perspective, because this absolutely went to juvenile court and later criminal charges were pressed, is this child's vitamin D deficiency with no evidence of rickets, meaning the vitamin D is low, but the bones look completely normal, did that predispose this baby to get a lot of fractures from lesser trauma? Well, that's a great question. And I just have to highlight the literature in this area because I think it's fascinating. I always describe the the experience of testifying in these cases is walking through a minefield, all the things you can and can't say, you're not allowed to refer to, etc. Well, the literature in child abuse cases and in the child abuse realm can be incredibly confusing because there are a lot of conflicting views. So here's a good example of my tour through the vitamin D literature. It's like 1 minute or less tour, so don't worry. Okay. Keller and Barnes, 2008. In pediatric radiology, they described 4 kids who looked very much like our baby. And these infants all had a lot of fractures, and he attributed that to vitamin D deficiency for multiple reasons. However, there were no, if you actually look in this paper, there were no vitamin D levels checked at the time of evaluation. Interesting. Multiple fractures occur spontaneously in young infants with subclinical vitamin D deficiency and insufficiency in the absence of radiographic signs of rickets. Well, that's concerning, right? And that seems like that would apply to our case. Here's, let's see here. These were further things they said. And in Pediatrics, Dr. Patterson, he wrote a commentary supporting Keller and Barnes, again in Pediatrics, a great journal. And later Pediatrics published that, in their full disclosure, they weren't aware of the fact that Dr. Patterson's no longer allowed to testify in the UK and lost his license because of his involvement in testimony regarding this concern. So again, difficult. If you don't see this retraction or comment by Pediatrics, it's hard to know about that Patterson article. This was Chapman et al. In 2009. This was in Pediatrics Radiology. They actually decided, well, let's go back and look at infants with vitamin D deficiency and rickets and fractures. And they found out that, in fact, or suspected that, in fact, fractures occur in older infants and toddlers, and they don't look like the same type of fractures we see in non-accidental trauma. And so that's really helpful. For instance, those kids we see with rickets, most of them don't have any fractures. Some of them have 1, 2, 3, and 4. And in the hundreds of kids they looked at, they didn't see more than 4. Although it certainly could happen, they looked different than those highly specific non-accidental trauma fractures. Schilling et al. They also published in Pediatrics in 2011 and found that there really is that there is not a strong association between subclinical vitamin D insufficiency or deficiency and fractures without some other evidence of bone problems on your x-rays. So that was helpful, but it does point out the difficulty in navigating the medical literature in child abuse. Okay. We still have a lot to know, though. We don't have a great idea of how to calculate bone mineralization in children, and I think there's a lot of work to be done. So what eventually happened in this case, so in juvenile court, I testified in juvenile court, and the judge did substantiate abuse. In criminal court, that did not go because dad did confess to hurting the infant and said that he had initially hurt the infant 2 weeks before, was gone for 2 weeks, and on the night of returning had hurt the baby's legs again. And I think it's just helpful for us to also remember that re-injury to already broken bones can cause acute inflammation, swelling, etc., and can cause delayed healing because you don't have that immobilization. So in this case, we certainly found out the answer, but I think highlights the multiple challenges that can arise along the way. Okay, so now what I'd like to do is, we have about 15 minutes left, and I would invite us to ask questions of the panel, as well as I know the panel has some important points that we've talked about before. And I know Detective Dobie, you may want to start.
The thing, I've investigated child sex abuse and felonious child abuse for the past 6 years. We have 8 detectives in our unit that investigate cases like that. 1 detective that's just tasked with the responsibility of runaways, which a lot of times, as I'm sure y'all know, when the runaway comes back, a lot of the time there's been sexual assault while they're gone. In addition to that, unfortunately, a lot of times kids leave home for a reason, and there may be something else going on in the home that caused them to want to get away from that. Since May 1st, 1 January to 1 May 2013, we've had 109 sex cases and 17 felonious child abuse cases amongst our 8 detectives. And one of the things I talked to Dr. Goodpasture about was in the initial interview that medical personnel are doing, yes, we want to know exactly what happened to bring the child into the emergency room or into the doctor's office, but something else that really helps me is if you can get a history a little further back than that, and for it, what I'm talking about is who are the caretakers for the kids. Because if you can nail down with that mom and dad or mom and boyfriend or whatever the relationship is to the the caretakers, excuse me, of that child. That helps me when I go into the interview with somebody who either did the abuse, they did know, or they should have known that a child was hurt. So I'm trying to think.
And I'd also add with that we ask who is in the house, that it might not be the caretaker who's with them, who are the older siblings. So we sort of try to get an idea for you before they start getting suspicious that you're worried about something. I guess you were stating when we were talking about this that a lot of times when you show up, people aren't exactly excited about talking to you. So for the physician, for the resident, we can ask those questions, and it won't be accusatory, and we can get that set for you from the get-go.
Exactly, because it looks like they're really caring for the child and they want to help the kid. But when I do get in there with the taser and the gun in a closed interview room, which the walls are so inviting because they're ugly gray, it starts the nervousness in the parents. And you know, I've already talked to the doctor, so I don't understand why I have to talk to you, Detective Dobie, so we can run into that.
And I think it's important to point out that there is an exception to the hearsay clause, meaning if a mom tells their neighbor something and then it goes to court, the neighbor can't just say what the mom told them because that's hearsay. But there's a medical hearsay exception clause, meaning if we are in the course of a medical evaluation, if we hear something from caregivers, we can get on the stand and testify to that, which is important. There are not other hearsay clause exceptions that I know of. Detective Dobie, you may know of others, but it's an important thing so that if folks give you history, document it, because we can testify to what we heard. Using quotes and being specific, if at all possible, I think is really helpful.
I just have a question. How important is it that nurses document when they hear the parents in the room at night talking about something?
Great, so how important is it for nurses to document? Absolutely important. It is so helpful, and I think what we sometimes experience is this gestalt suspicion that everybody has, and oh, we're so worried because that parent is inappropriate or they've said inappropriate things, but actual examples is what helps DSS and law enforcement put it all together, put the pieces together.
And we train our residents to write in quotations, not say, mom's acting suspicious. Really, this is such a team effort that doctors, nurses, we have to work together, and really the nurses spend so much time. They sometimes get those situations where the mom is yelling at the dad or the dad saying something, that if you can put that in quotation marks, that really means a lot to investigators. And it also, it might look suspicious when you look at it, but you don't put that qualifier on there. Let other people make a decision whether it's suspicious or not.
And you'll think you're going to remember in 2 years when you're on the stand, but you probably will not. I do not. And so don't just say, well, I'll remember. You probably won't remember. It can take a very long time for these to go.
How do you handle a child telling you about the abuse? Because I have this 3-year-old girl that told me mom did it, and I tried to document, and they came back and told me not to, and I didn't know how that works.
We're going to hand off to Miss Elizabeth Goodman in this.
So generally when we talk to children, we ask for permission from the parent. We're just going to talk separately. We go into a separate room. We have to get permission up front from parents. We want their cooperation because they're going to shut down if we don't get their cooperation. A lot of the things that the sexual assault nurses and forensic nurses do and the things that we keep as far as records, those are all received with parental consent, which makes them, I think, more powerful. You generally have the concerning party bringing that child in, but they very well may be having conversations with someone else. I have more than once been sitting with the mother and she's been on the cell phone talking to whoever maybe the potential perpetrator is, and she will hang up with them and say to me, he's scared that he's in trouble, or he wants to know what we're talking about. He keeps hammer calling me. He keeps texting me. And so then a lot of times I can use that information. Plus, if I have spoken with the child separately, those can be linked together. And I'm just doing my nursing job. I'm not doing anything investigative. I'm just doing what I think is the right thing, what I'm being told as far as what the scenario is. But then we talk to the child individually, and then we talk to the parents separately too, so that they're not discussing things in front of the child as well. And we make sure that we have 2 separate narratives so that those could be kind of tied together by the investigators, but that more information can kind of come out and that we get it on paper.
I think it's a good question, and it just speaks a little bit to the talking with kids when there's a concern for abuse. There are a couple of things to remember. One is you can always document in quotations what you said and what the child said. It is what it is. Sometimes they just make those statements spontaneously. I had one of those in clinic the other day. I asked about any type problems with enuresis, and he said, yeah, I got whipped here with a stick because I, peed my pants. So I'm just going to document that in quotes because they will make spontaneous statements. If we're going to talk with a child, we have to think about how we're going to do that, why we're going to do that, and who's the best person to do that. So at our institution, we always like to think about who's the best person, and we have folks like the sex assault nurse examiners and social workers and myself, and we have some more training in talking with kids because kids can be led. We like open-ended questions if possible, like tell me about why you're here today, why did mama bring you to the hospital, etc., rather than did daddy touch you in your poo-poo with a stick or whatever it is they said. So we try and ask open-ended, not closed-ended questions. And we need to gather information to make medical decisions. And if we relate it back to the medical decision-making, I think that's the important thing to remember. We're not investigators. We're doctors and nurses, and we're trying to provide the best possible care for that child. And we may need to know if somebody punched that child in the stomach. That can definitely change our clinical course. We need to know if that child's been had mucous membrane contact from sexual abuse because that changes whether or not we check for sexually transmitted infections. We need to know if there's a reason to concern or to have concern for pregnancy. So we need to get this information. We absolutely want to do it in the most a responsible way possible, meaning we aren't going to try and ask closed-ended questions. We're going to document really well. And we're going to try and develop a system whereby when these things come up that we have a plan in place. But we absolutely need to get the information sometimes to help take care of that child medically.
But still, when you're in her situation and you're on the floor and that patient tells you that and you're not trained like you ought to train, and then somebody tells you not to document that, I mean,
I would never say not to document that. If somebody tells you something spontaneously, I would document it. If it's important and it is uttered in that room.
But if you're in her situation, who can you contact to say, hey, how do I put this in there? I mean,
I see your point.
Obviously, her co-workers or the powers that be that were over her told her, no, you can't put that in that chart.
Well, in our hospital, there's a child abuse physician on 24 hours a day, or someone from our team, 24 hours a day, 7 days a week. So, yeah. So you can always call us.
Okay.
I would call us
okay.
and ask. And so I think that would be a starting place, your supervisor, although that may, I'm not sure how that.
Because everybody has a different idea of what's supposed to go on. Not everybody's knowledge.
And I've heard a lot, right. Right.
And it's like you don't want to be led astray.
And you shouldn't have heard, you shouldn't document that because then you're going to have to go to court. Well, it's true. It happens sometimes. As doctors, and nurses, we may all have to go to court. I can tell you, though, that you will survive it, and it will probably be not that horrible. We testify together. There are folks that are not in child abuse pediatrics who testify all the time. There are residents who testify. You will survive. I would not let that prevent you from documenting, although I hear that all the time. They told me not to document because if I put that in the chart, I'm going to have to go to court. It's all you have to do when you go to court is tell them what you heard and tell them what you saw. And that can be incredibly important for protecting that child moving forward.
When you're talking about documenting everything, the thing about, and it's not always 100%, but the more airtight you can make my case with quotes, and then we show that a child has been consistent over time. If they go in the ER on 4 November, and then I don't get to them, whether it's me interviewing them or providing a referral to do a forensic interview for that child a month and a half down the road, and it's still consistent with that documentation, that makes my case more airtight. The prosecutors like that, and a lot of times you don't have to testify in court because we get a plea out of it.
I would agree with that. Very few of these cases actually go to criminal court. Very few of them. And you should never let that deter you from documenting, but just remember that too, that it probably are not going to have to testify. And this whole changing history thing is critical. I can't tell you how many times we look back at the outside hospital documentation or the ED documentation, and it differs from what I'm now being told, And then I call that doctor 1 or 2 days later, so I know they haven't forgotten it. And I say, this is what they're telling me. Is that really what they told you? Yes, and I can document that I did that. That is critical to the history, because very few times do the injuries alone speak for themselves. Meaning we can't just look at the injuries and say this child is definitively the victim of non-accidental trauma. It is an entire picture that is critical, because again, we don't have things that are pathognomonic for non-accidental trauma anymore. We need the whole picture. I saw a question, a hand. Yes?
Because our facility now has the abuse protocol in place where we have a lot of times sitters, non-nurses, non-doctors, non-security, sitting in the room. I've had several of them come to me and say, hey, I heard the parents say, how do you document that? Because they heard it, not me, but they have no mechanism to document in an electronic record.
They do. They can document, but it won't go in the electronic medical record. They can document through their security system.
Not security. We have sitters. We have NAs. We have secretaries sometimes being sitters.
If there's ever a question about where to document, you can call us. Folks can document. I document and I keep it in my office. I document when I hear something and I'll keep it in my file cabinet sometimes if it's not able to go in a patient record, or if I was called and it's not an actual consult. So you can always document. In fact, we tell folks who are interacting with folks in the community, if you see or hear something that's concerning, just write it down. Take your time to write it down, and then as things unfold, you can figure out where this should go in the next 24, 36 hours. We can work through that, but I would write it down, and then we can figure out where we should put it. Right. You could always give it to the police or to DSS. No one really should be, in my opinion, and Dr. Petty, you can tell me if I'm wrong, no one should be able to tell you can't document something. You can always write something down. And I've never heard of somebody telling you, or there's no hospital policy that I know of that says you're not allowed to write something down. And writing something down helps you keep from getting confused later on.
But the sitter wouldn't necessarily be protected by the hearsay rule, right?
Absolutely, everybody is. So good faith reporting law, meaning if you in your heart of hearts feel like a child is being abused and you make a report, then that good faith reporting law is going to apply to you. If it doesn't apply to you, we hear about some manipulation in reports. So that doesn't help if there's a custody dispute and a mom makes a report on a dad because they're in the middle of a divorce, etc. That's not a good faith report. But if in your heart of hearts you feel like a kid's being abused and you make a report to investigators, you're going to be protected by a good faith. Now they may drag you through the mud, but at the end of the day, if you in your heart of hearts believe it, then you're okay to report. And you should report, right? Because we've seen that also retrospectively. We look back and say, well, somebody else will report this, where it's not my job to make the report. In North Carolina, whether you're a doctor, a nurse, a teacher, or you are just at Shoney's and see somebody slam their kid, you're a mandated reporter. And there are civil charges. There's no good faith or good, there's no law to protect you if something bad happens. You can be sued in civil court for damages if you failed to report and you knew abuse was going on. So it doesn't work the other way.
And let me just add real quick, if our sexual assault forensic nurses do see children up on the floors at times, and oftentimes we're asked by law enforcement or DSS, how did you get involved? Where was the first spark initiated? And if it was a sitter that had a statement, we can certainly scan in their statement into our paperwork. That's totally
Absolutely.
Okay.
And I will put in my documentation when other folks hear things, and I'll put their name down so that DSS and law enforcement can talk with them, and they can, it's not essentially, third person. Oh, yes.
For pre-hospital providers, what are the important things that we need to document and look out for in cases like these?
Great. So I think history is important. So documenting as much history about what happened, when it happened, where it happened, who was there, what did they do about it, how long did it take you to come to the hospital, who else knew about it. Oftentimes delay in seeking care is a big red flag from a history perspective. So talking about history, I think and documenting that can be really important and helpful. And then pre-hospital, I also think reporting is a big, is something that's important. And so if you're pre-hospital and you suspect abuse, I think it's important for you to make that report in addition to the report that the hospital is then going to make, because you're going to give that firsthand knowledge about the child before they came to the hospital. We're going to then tell them about what we know since the child's been there. But we will, I think, sometimes look back and find that it would be incredibly helpful to get that pre-hospital experience in the PCP's office or the outside ED. And so having that information straight from you all, I think, is really important and helpful.
And I'd add to that, to pull the attending aside and talk to them. The residents may not have a handle on how important that is, and obviously I would write in my note that you had concerns and we discussed it and you're going to report, or I was going to report because of that. But I think pulling the attending aside would be a very beneficial thing, and we definitely need to listen to y'all and get your perspective, because it's one of those things that until you do EMS ride-alongs, you don't really know what the house looks like, what the conditions are the child's in, and that means a lot to us.
Our report, and remember law enforcement, so sometimes folks are concerned or question, do I report to DSS, do I report to the police, or do I report to both? Well, you can always call us at Wake Forest and we can help that. But if there are serious injuries or if there is something illegal going on, then you need to call the police as well as DSS. DSS has 3 response times, either immediate, 24 hours, or 72 hours, and they qualify the report and it goes through this protocol to see when they're responding. So it doesn't mean that they're automatically, in many cases, assuring safety with this child or the 3 other children who are at home with the possible perpetrator, right? So that's where the police can be extremely helpful. We want to get them involved early because it helps them in their investigation. It's going to be incredibly helpful for them to come in that evening and go interview all the folks, as opposed to 3 days from now after we get the MRI back. So we need to call them when that suspicion arises so that they can help, because even if it turns out that it was an accident, they may be able to get the additional interviews that evening, and everybody's story lines up, and in the end we all think it was an accident. That doesn't mean that law enforcement was the wrong decision. It just means that they helped in the process and we helped them through the process too. So if you are suspicious and there's serious injury, we need to make a report to law enforcement. Or if the law reads if there's serious injury, but if there's something illegal, so child pornography, sex trafficking, etc., we're obviously going to make reports to the police as well. And I'm a big fan of reporting to the police, because you know what? They come right then. They come and they help you figure out how to make sure this child's safe and how to make sure everybody else is safe. So just remember law enforcement reports.